So I only have half an hour today because I have to be off campus, which will be a short presentation, and geared toward our students who just started on the medical wards, and then toward our interns who are going to be senior students. And then our lovely senior residents who are present can also give their advice and input to this presentation. So what I want to talk about is how to provide some real-time feedback when somebody is presenting to you. And so in my mind, there are a few domains when thinking about and listening to a presentation. And as I've attended now a few times at the VA and here, it's really hard to focus on all of these at the same time and also listen to the content of the presentation. So what I'll tell my students or my interns is that, hey, today we're going to focus on how you present your objective data, and I'll give you feedback on that, and so they know when the feedback will be coming. So try and pick one of these domains to focus on, and you got to begin with organization, because if the organization isn't there, it's going to be hard for you to focus on any of these other ones, and so really get that out of the way. If your presenter isn't organized, start there, ask them again and again to reorganize their presentation until the organization is as we want in internal medicine. And then thereafter, you can start focusing on how they present their data. So then I think about the objective data, physical exam, vitals, labs, and how they're presenting those. At the start of the year, I ask folks to present the entirety of the labs, and and then I ask them, hey, that BMP you just presented to me, is that normal or not normal? And as long as they can prove to me that they know what normal means, then in the future presentations, they can start saying BMP was normal. But you have to recognize that sometimes a creatinine of 1.3, which isn't red and epic, is still abnormal if it bumps from 0.7 for a really thin person, right? So it's these little things that we have to pick out as the intern, senior, or the attending. And then interpretation of the data and assessment and plan kind of go hand in hand. But the biggest mistakes we see in assessment and plan are not organizing your problem list by acuity. And so the thing that's going to kill the patient the fastest is what I put as my #1 problem, right? And then there could be a couple of problems that are competing with each other, and you just have to decide which one is the more pressing for the day. And then discussing a differential only when appropriate. If you know the person has a GI bleed from an ulcer, you don't have to talk about your differential every day, because now we know what the diagnosis is. Making sure that the plan is logical and feasible for the day, and then always including a checklist. And today we're talking strictly from the ward side. Danny has an excellent presentation lecture on ICU side on our YouTube channel, and so check that out. But today we're only talking about ward presentations. And then lastly, any miscellaneous thing that you might notice about your presenter, whether they have a habit of swaying when they present, or they're talking too quickly or slowly, if they include a lot of ums and likes, or if they're editorializing, all of these things are sort of at the end that you can help them out with. So what we'll do today is a practice presentation. So I'll be the one presenting, and you guys will give me feedback on my presentation, okay? So why don't we have a few people volunteer to focus on each of these domains. And so maybe our intern, Alana, Jonathan, if you guys want to pick one of these domains and tell us what you want to focus on. Okay. Organization. Okay. Alana, what do you want to focus on?
We'll do number 2, objective data.
Reporting of objective data. Okay. Yeah, what do you want to focus on? Assessment and plan. Love it. Okay. And so we'll focus on those, and then the interpretation will sort of be in the assessment and plan. So Gia, you can tell me how well I'm interpreting the data I'm presenting. Okay? All right. So this is going to be an H&P presentation, so a patient that I have just admitted from the emergency department. All right? Okay. All right. So today I have Mr. X. He's a 57-year-old man with a history of hypertension, hyperlipidemia, COPD, femur fracture, status post plating. He has type 2 diabetes on insulin, and HFrEF, who is presenting with swelling. And so he told me that he has stopped taking his medications and noticed that he was gaining weight over the last 5 days, and he remembered that his doctor told him that he should be increasing his medication, but he just doesn't like going to the bathroom all the time, so he didn't do that, and so therefore got more and more swollen. Tells me that his pants don't fit well anymore, and so That's why he came into the emergency department today. He's also been feeling more dizzy, he's having some nausea. Another associated symptom is that he's having some shortness of breath and cough. He says his cough has a little bit of mucus production, but not so much. But he does have COPD, like I said. And then his legs are swollen, they're a little bit red. It didn't look like cellulitis to me, but I'll talk about that more in my exam. And then no fevers or chills, no passing out. He does feel like his heart's beating kind of fast. Yeah, that's it. So then for his home meds, he's supposed to be on amlodipine, he's on hydroxyzine for anxiety, he's supposed to be on metoprolol, he's on Lasix, on a baby aspirin, simvastatin, and then he occasionally takes NSAIDs for pain when his hips act up. Social history-wise, he currently smokes a pack per day, he drinks socially, he denies any drug use, he lives at home with his wife, and he was working, but lately he's been on disability. As far as allergies goes, he doesn't have any. I already talked about my ROS in my presentation, nothing else to mention there. So for vital signs, he was afebrile in the ED. His heart rate is 126, his blood pressure is 152/82, and he was statting 90% on 4 liters of oxygen. On exam, he appears in mild distress because he's moving kind of fast. He otherwise looks okay though. His heart exam is irregular rhythm, that's tachycardic. I didn't hear any murmurs, which is good. And his lungs, I hear crackles, sort of all over, but I wasn't sure. And I don't think I heard any wheezing, but I'd like you to check for me. His belly exam is non-tender, it's soft, it's not distended, and then his legs have 3+ edema up to mid-size. I did notice some redness and erythema, but like I mentioned, I don't think that it looks like cellulitis to me. As far as labs go, on BNP, his sodium is 131, potassium is 4, chloride is 108, bicarb is 22, creatinine of 52, and BUN of 52 and creatinine of 1.7, which is up from his baseline of 1.1. His glucose was elevated at 250. His CBC is normal today. His LFTs are stable. His A1C is 10, and his lipids are elevated with an LDL of 155. Is there anything else you want to know on labs? They did get a BNP in the emergency department, which was 1,300. And the last time we have in our system was 400 from 6 years ago. Okay, his chest x-ray looked like the radiologist said that it looked like pulmonary edema with vascular congestion in the hilar regions, otherwise no cardiac abnormality. So my assessment and plan for Mr. X, he's a gentleman with hypertension, hyperlipidemia, type 2 diabetes, femur fracture, HFrEF, who is NCOPD, who's presenting with swelling. So my number one problem is his volume overload. I think that he needs to start taking his Lasix again, and so I would give him some Lasix. The emergency department already gave him 40 of IV, and it looks like he peed 1 liter on that, on his I's and O's, and so I would do the same thing again tomorrow. And then restart his home metoprolol and his aspirin and statin. I think that his shortness of breath, which is my number 2 problem for him, is probably a COPD exacerbation, and so I want to start him on steroids and antibiotics like we do for people with COPD, and see how he does on that. And then, yeah, he's tachycardic. Oh, I forgot to give you his EKG. Here's his EKG. So again, I think he's tachycardic, and so I want to give him a liter of fluids to see how his tachycardia does, because I know that generally, like, people are dehydrated and can have tachycardia. So I'm gonna do that and then see how his heart rate does. I'll put him on telemetry monitoring. His potassium was normal. But I would like to add on magnesium to the lab to see if that's low or not. His A1C is high, so I think we should get a diabetes educator consult, so they can talk to him about, his diabetes medications. I didn't see any on his med list, so I don't know if he's on any. And then I put him on a regular diet. He's on heparin, and he's full code, full Q. Okay. So let's start with my organization. Yeah, it's hard, right? Because then you're like, when you're in that role, you have to remember everything. You're trying to take care of the patient, so it can be difficult. So try your best.
Like, first thing I noticed was like even just organization of the HPI was a little off, like kind of bumped, I feel like in and out of review of systems, so kind of presenting with volume overload when I hear all those cardiac symptoms kind of together in this presentation, but otherwise started okay. And then having like kind of other review symptoms at the end of the HPI, I'm fine with. I think like mentioned like past medical history in one liner, but then you go into it. Detail after that. Have people talk about past medical history and meds together, and then the medications can be a little more organized rather than just a list of medicines. Because like when I'm listening for a patient in heart failure, like I want to know what their GDMT regimen is, what their home Lasix is. So it's nice to just mention that with their past medical history. In addition, I think maybe not super contributory in this case. We didn't like talk about surgical history, I don't think.
Yeah, or family history, I think too.
Like always relevant. And then I'm trying to remember where we went next. Social, and then I think started like objective wise, okay, like started with vitals, went to exam, and the exam was actually pretty well organized, like general exam first, cardio pulm, peripheral, and then like again started okay, like presenting laboratory data. I kind of like to hear CBC, BMP first, because that's the order I think of in my head, but then any like associated studies. I think missed the BMP there, and like obviously could have put that as a more relevant lab right up front, and then not doing like the EKG.
Forgot to.
Because that's a pretty important thing in this problem. And then, not to tread on GA stuff, but not stepping in like the medical processing, but just like organization of the plan was a lot of, here's a problem, and like, here's some steps I want to do without like a real assessment first. It was like a lot of plan and not a lot of assessment. So like, first thing after I hear a problem, like volume overload is like, what do you think is going on, before we talk about what we want to do or what's already been done.
Yeah, great. Yeah, so I think the organization was fair. I think everything came in the order we would expect: subjective, objective, assessment, and plan. But in the subjective, like we talked about, just really grouping the HPI and then going into the ROS is helpful instead of jumping in and out. And then sometimes we'll say, like, if a patient came in with shortness of breath and got a CTP in the emergency department, sometimes it's okay to present that data up front to say the CTP in the emergency department was negative, and before the patient came to the floor, they received 40 of Lasix. And so sometimes it's okay to put that stuff up there, and people often shy away from it, but it's important information to know. Great. I think I did a good job with the vitals and the physical exam. Just remember that vitals in internal medicine, we prefer to do ranges, and so try to provide ranges for heart rates and blood pressures if you can. And then assessment and plan here really need a lot of work, but the organization of the problem list wasn't great. And then the other thing that also sort of is an organization is how you talk about the problems. Instead of putting problem number 1 as just volume overload, you can say volume overload secondary to HFrEF exacerbation, or just something to like actually help us understand why you think the patient's volume overloaded. Yes?
For the problem list, if one problem is perhaps like not the thing that's gonna per se kill the patient, but is preventing the resolution of other symptoms. For instance, like we had a patient this morning that had like AKI, and then that was preventing us from, doing like more aggressive treatment with other things. Is it appropriate to put AKI first, or would you still have it lower down the list, even though the other ones are contingent on AKI's resolution?
It sort of just depends, if this patient has an AKI too, right? But, their respiratory failure is probably the most pressing issue. So you can also say like shortness of breath and volume and pulmonary congestion or pulmonary edema due to heart failure. But, it depends, sort of AKI could be your number one problem if that's what's preventing the patient from leaving the hospital. But it's unlikely to be the number one problem on day one unless that's really the reason they came in, because they're like, I'm not peeing at all, and they're creatinine 4, then yeah, AKI is their number one. So it sort of just depends, and that's what your interns and seniors will help you with, is talking about how to reorganize your problem list as the days go on, and so that's their job.
Yeah, I'll have something to say about that, Evan. And sometimes what you can just do is, in one, this is just purely organizational, but sometimes I like to just, state, the plan for this problem and then say limited by AKI or something like that. And you're gonna talk about the AKI later. So it doesn't necessarily have to be, remember the prioritization of problems, can vary from attending to attending, right? But obviously you don't wanna put, for his type 2 diabetes, that's chronic and unchanged, that's your first problem.
Understood, thank you.
Great, okay. Reporting of data.
Okay, let me try to remember it. I think, you already mentioned that we prefer to have vitals in a range, so if you could mention the ranges of those, and then often with vitals, you also include ins and outs.
Yep.
And, especially in this patient, it'd be important to have daily weight, or like their weight, and what their baseline weight is, if you can, get that. And then the other thing, going back to the vitals, so especially like with tachycardia, it sounds like the patient has been on a beta blocker, so it's helpful to know if they had a beta blocker that morning, and that's their tachycardia with a beta blocker. The other objective things would be the physical exam. With like volume overload, there's some other stuff for like JVD, I don't know if you mentioned that.
I didn't mention it, so yep.
And I can't remember, so I don't remember all the medical problems, I'm sorry, but we can, let's see, yeah, the volume overload, and then.
Yeah, so
Yeah.
I mentioned that, I wanted you to help me with wheezing, because I wasn't sure if he had any. Yep.
Got it.
Yeah, but I think otherwise, the
physical
exam
exam
was
was
fairly
good.
okay. I
Yeah,
just missed the GBD. Yeah.
Okay, great. And then as far as labs, you mentioned the baseline creatinine. It also, for some patients, it's helpful, especially if they're elderly, to know their creatinine clearance, because that's gonna affect medicine, and that's on Epic. And then, I think for most of the things you mentioned a baseline, I can't remember, like, for hemoglobin and like a white count, if they have one, it's helpful to know that, but I don't think we had a white count.
I just said CBC normal.
CBC was normal, okay, yeah. So, I guess like one piece of advice I would give just generally for like a new surgery would be like the things in a CBC that people would like to know typically are like the white count, the hemoglobin and platelets, and most of the rest you can ignore, unless it's like pertinent. And then as far as the BMP, I think you mentioned like later on in your presentation that we can have a MAG, but it would be helpful to know, like, I guess when you're talking about that for organization purposes, that we're waiting or hoping to get a MAG. I think those are the main things.
Yeah, any other comments on my data? Yeah.
Just piggybacking off of what Alana said with, values on the CBC, it's always good to know baselines as well, which I guess could also go in the assessment and plan, but sometimes I like to hear it when they're.
Right, okay. Yeah.
I think we often, and we kind of have interpretation and assessment bleed into all parts of our presentations when it shouldn't, but we tend to do that a lot on the exam, like erythema that doesn't look like cellulitis, like you could instead say like poorly demarcated erythema, not warm to the touch, like things like more objective findings, because we say that a lot of like, even like abdominal exams, like non-painful, when it's like really tenderness we're looking for, it's like we just kind of like interpret the exam as we tell it, instead of like assessing that.
Yep, I agree, yeah, so probably not. And then, the one last thing, I don't know if you guys caught on, but I said LFTs were stable, and I think that's gonna be a pet peeve of most attendings, is when you say things are stable, please only say things are stable if they truly are stable from the day before. If it's the first time you're getting a lab, you don't know if it's stable or not, and people often also do that with vitals, and so instead of saying vitals are stable, I just present vitals every day, even as an attending, I just say the ranges, because it helps the team recognize what they are, and sometimes hidden things are not okay for a certain patient, and so just want to keep an eye on that. Like in a patient who we're trying to aggressively diurese, that's here with heart failure exacerbation, even a blood pressure of 130, which might be normal for them and stable from yesterday, isn't what we want, because we want it to be as low as possible so that we can help forward perfusion with afterload reduction. So early on when you're starting out, just present the data as it is instead of using terms like normal or stable, and particularly stable, which gets you into trouble. Okay. And then IB, assessment and plan.
Great. Yeah, so I think first with the one-liner.
Yes.
For the summary of the patient. You know, I don't know if there's any value in being redundant and repeating all of the different, diseases that this gentleman has. That being said, it's good to mention the more pertinent ones. You know, heart failure, AFib, what he had, right? Yeah, you know, things like that, and then, be a little bit more specific with, why they're here, presents with volume overload, presumably due to ...
Yeah.
Right? And sometimes it's okay to not have the answer at that point. And then I think also just, obviously this is an HMP, but like for further days, I always try to tell the students as well that it's good to include small tidbits in your assessment, as to what's been going on with the patient, what we've done, new developments, things like that. That's the first part, I think. As far as like problem-based, going down the line, for his different medical problems, I agree with what Jonathan said earlier. I think having a problem and then giving a good differential for what's going on, is also important, because there are a lot of different things that cause volume overload. You think of like, you know, liver disease, kidney disease, heart disease. And a guy with heart disease, you're probably going to say that this is the most likely etiology of his heart failure. And then giving very specific plans, not waffling as to, or rather, I should say, specifying exactly what you want to do, right? So maybe as a senior, you can get away with saying, I'm just going to give him some more basics, but earlier on, you want to be specific about what dose, how you're going to give it, how often. Are you going to be monitoring electrolytes, if you're going to be diuresing this person really heavily? And if diuresis is even the right thing to do at that point. Right?
Yeah, so for an example, like what I said was, let's just give this person antihypertensive and some more Lasix.
Right.
And that's completely vague, so what you should say is, today my plan is to diurese this person further. The ED gave a 40 of IV Lasix, which worked well, so I would like to redose with 40 of IV Lasix this afternoon, and then reassess in the morning. For blood pressure management, I'd like to start this patient on captopril because it's a short-acting ACE inhibitor. May or may not be good today because they have an AKI, so I'd like to know what your thoughts are, but that's what I would do today. So still put your nickel down, but understand that you want input from the rest of the team who have more experience on whether I can start this in a patient with an AKI today, or should I use a different one? And then, yeah, I would like to check a BMP this afternoon as well, because I know that patients that are being diuresed aggressively can drop their K and MAG. And then, good, so, and then talk about, you know, like, this is an opportunity where seniors, advanced interns can teach about GDMT. Is it like a golden goose here for HFrEF?
Yeah.
Okay, and then what about my other problems that I mentioned?
Yeah, so let's see, so you mentioned volume overload, you mentioned, I think, his diabetes.
And then my second problem was his shortness of breath, which I thought was
Right.
COPD exacerbation, and I wanted to treat that.
Right. So I guess it's kind of tricky. I personally don't always just like to put symptoms down as problems, mainly because symptoms are usually all linked to one diagnosis, right? And so maybe he's short of breath because he has fluid in his lungs. Although it can obviously be tricky in a person who has multiple different diagnoses and different respiratory. So I think with that, it's probably okay to say shortness of breath initially, but then you might want to say something like, you know, it's probably related to my first problem, the volume overload. But nonetheless, I want to keep COPD exacerbation in the back of my mind. He didn't sound, and then you can also toss in the different exam points. You mentioned that you didn't think he was wheezy. You know, he wasn't having increased sputum, or anything like that. I don't know if that was determined in the history or not. And so you can say most likely related to the first problem. You know, keep it on the back burner. I also wanted to talk about the AFib, or his tachycardia as well, right? So again, another symptom, but we know that he has an irregular rate. And so, so we know that.
Yeah, it's AFib.
I don't think I see would, yeah. So, so we know that he's an AFib, and we know that he's chronically an AFib as well.
I didn't say any of that, so maybe something that your seniors and interns will ask you to discuss a little further, like, hey, you didn't mention this person had chronic AFib, you know, it sounds like they're on metoprolol, did they take it today or not?
Right.
And then, yeah, my plan was for this to give him some fluids, just so
Right.
his tachycardia got better.
Right, and so I think that also has a little bit more to do with, knowledge or experience, obviously. You want to try and be less reactive, at least in medicine, and be more of a, think about what's the underlying problem, right? So if you think that this person is volume overloaded, and volume overload is causing all of their symptoms, then it's probably not a good idea to give them volume, right? Especially when you said earlier in your plan that you were going to diurese them. So you want to make sure that you're not contradicting yourself in different parts of the plan. That being said, also, it's good to have mention any prior EKGs, you know, is he on any anticoagulation for his atrial fibrillation? So that just takes a little bit more chart review, and that's just helpful information, I think, overall, during the presentation.
Go ahead.
So you just, earlier you were mentioning how, you don't write symptoms, but because all the symptoms come down to two diagnoses.
Yeah.
So as you progress and you find out problem 1, 2, and 4, 3 are related to one diagnosis, and you list that as a problem, do those other problems still fall under that, or do they just go away?
No, I mean, I would say, I'm sorry, I'll try to understand your question, because I think I slowed down first. So you're saying, like, when you have all of these different symptoms listed, and then you realize that they're all related to one problem, yeah, I mean, I guess essentially you condense them, right? Like, he could be an AFib because he's having an acute heart failure exacerbation, right?
But he still retains like the other diagnoses, right? So
Right.
problem number 1, decompensated heart failure, all of the other stuff associated with it. He still has atrial fibrillation, we'll treat him with metoprolol and likely start anticoagulation. Still has COPD, what are you gonna do for his COPD? Because I don't think that it's contributing to the acute presentation of wide pain.
Does that answer?
Does that make
Yeah, you've gotten there to that, because earlier, you can think of breath, not shortness of breath now, the diagnosis of heart failure exacerbation can fall under that, or?
Yeah, at that point, you would just say that, acute decompensated heart failure rather than shortness of breath, right?
And then the way I think about it is you can also think about it from a management side. So think about it. So if I give this patient Lasix for his decompensated heart failure, will the Lasix treat his leg edema? Yes. Will the Lasix treat his pulmonary edema? Yes. And so then therefore those don't need to be separate problems, because they'll be encompassed under the management of our major problem, which is decompensated heart failure. In the same vein, his atrial fibrillation shouldn't go under that first problem, because the atrial fibrillation has separate management that I'm thinking about actively, in the sense of, will I put this person on long-term anticoagulation, which isn't necessarily a treatment for heart failure, right? Will I put this person on a different dose of metoprolol? Does he need something like a drip right now? Does he need amnio right now, right? I'm thinking about all these things separately, which aren't treatments for heart failure. And so if you're thinking about different managements, they probably need to be different problems.
Management was extremely helpful, so thank you.
Yeah, and I would say, like, I think it's really okay on your H&P, but actually I would favor doing symptoms on your H&P, just so we make sure we don't
Yeah, that's fine.
anchor down to one diagnosis too quickly, but like, think about how your symptoms relate to what you're calling your diagnoses. So like, you know, shortness of breath, it's fair to like put that separately and say, could be this, favor this. But I would actually say in the H&P, be as broad as you need to think about the problem, but really put your nickel down on one management, and then as you like go throughout, your progress notes should get more and more condensed into just specific diagnoses. You shouldn't really still have shortness of breath by day 3 of hospitalization, because at that point, you're either treating pneumonia, heart failure, or COPD exacerbation. Like if you're still like, well, it could be this, this, or this, and you're not doing like a good job at hospital stay. Like, you shouldn't still, like, we don't need differentials by day 3 of the hospital stay, but like H and P, be as broad as you need to be to think about it.
And then, so in the same vein, like, if this person didn't come in with an AKI and now day 3 has one, then it's okay to put that as your number 1 problem, because maybe their AFib and heart failure are now on cruise control with certain amounts of medications, but this new problem has popped up. So now, today, day 3, my number 1 problem is AKI. My differential for it is pre-renal, intra-renal, post-renal. I'm going to talk about it and talk about my management for today, which might be, hey, I think we ended up over-diuresing him because his bicarb is now 32 and he's contracting. And so let's hold on diuresis today. Maybe let's give him a very gentle bolus to see what happens. Let's not do anything and see what happens to the creatinine tomorrow, right? Like, it just depends on, as the days go on, how you organize. And then I really do want to stress the logical and feasible plan of it. You know, in patients that you're aggressively diuresing, you have to decide, like, hey, how aggressive am I being? Do they need a Foley today? Because I can't make them go to the bathroom 21 times a day, and they're going to end up having a fall on my service, right? So just thinking about, like, what's feasible in the hospitalization and how quickly can I do something. Yes.
In terms of, like, getting to, finding a direction for treatment, and, like, putting the nickel down, I guess I'm sort of confused as to, like, I'm coming out of the part of the education where we got, like, multiple choices to pick from, and now there are just all of the medications to pick from. And I was wondering, I'm like, I'll go to first aid, I'll go to, not first aid, sorry, I'm upstate, not first aid. And, you know, and like, I'll search what I think the symptoms are, and so on, I'll see, like, the first response, and I'll pick that, and, like, that's where I'll put my nickel down. But it feels like I'm throwing away a lot of nickels that I know aren't gonna be right, but I'm just, like, putting things down just to accept them.
Yeah, so what we care about is not the right nickel, we just care about a nickel. So instead of saying, okay, for this heart failure, so instead of saying, like, I want to diurese them, that doesn't tell me anything about what you understand about diuresis or what meds are available for it. But I also don't want you to say, yes, we can diurese them today. The options are Lasix 20, torsemide 10, hydrochlorothiazide 50, and spironolactone 25. And then problem number 2, right? So then it's like, well, which one of those would you like to choose today, right? So just say, today I want diurese with spironolactone 50, problem number 2. And then your intern and senior will be like, we'll have an opportunity to teach and be like, listen, the mainstay of diuresis in heart failure exacerbations are usually Lasix. So instead of doing the spironolactone, let's do Lasix today. And then why not tomorrow rediscuss whether the patient is ready for spironolactone, because it is one of the goal-directed medical therapies for heart failure, right? So we just want you to pick an option, and even if it's just completely wrong, that's fine. That's why you're here. And that's what we ask of our interns too, is just like, pick a plan. If you're unsure about it, either discuss with your senior before rounds to enact it, because sometimes, right, we want the patient to get their Lasix at 8 a.m. as opposed to noon after it's been discussed with the attending. So if you're unsure, talk to your senior and they'll be like, listen, we're just going to do Lasix 40, please give it. If the senior is also unsure, then we can talk about it on rounds. And that happens especially on days where you're like kind of contracting, you're not sure if you want to keep diuresing. And so a senior will be like, listen, I'm not, you know, I think we should still diurese one more day, but I'm worried because they've contracted. And then the attending, with whatever art of medicine they're using, will be like, in my experience, right, there's no longer evidence on that day where you're just using your experience. It's like, in my experience, usually this patient's going to end up with an AKI, so why don't we just give a day to equilibrate and reassess with a BNP tomorrow? Or why don't we today just go to oral Lasix and see what happens, okay? Yeah, but just pick a plan, even if you think it's completely wrong, it's fine.
Thank you.
Yeah.
Can I say one thing?
Yeah, please.
And so, in the vein of editorializing, kind of, and throughout the presentation, say less. Like,
Yeah.
Like,
That's just good for all of life.
it makes the presentation flow better, it makes your plan even look better. Without even having the right plan, you will look more like know what you're doing more, I guess. But I think we tend to do that because we're shy about, oh my gosh, I'm standing in front of a group of